Hi, my name is Taryn Lorenz, and we will be discussing my practicum with the Divisional Charge Nurse of the Trauma Surgical Service Line and the educational needs of spine mobility and precautions. Leadership is something that I have always been interested in. My practicum was with the Divisional Charge Nurse, DCN, of the Trauma Surgical Service Line. The DCN has many leadership roles and responsibilities and works closely with the House Administrator, also known as the HOA. The Trauma DCN has many roles and responsibilities, but just to name a few, they assist with patient flow by coordinating with the HOA and physician teams, assist with monitoring quality measures and assuring Joint Commission readiness for all shifts, provides assistance with staff mentoring and educational support, provides added leadership oversight for the service line, and is the first line of contact for the service line when nursing leadership is not readily available. As stated on the previous slide, leadership is something that I have always been interested in, and it is something that I become more interested in as I develop and advance my nursing career. I am currently not ready to leave the bedside yet, but having been a nurse for a few years, I am ready to move forward to what's next. So a bridge between management and bedside nursing would be the role of the DCN. One of my main goals and the prime reason for choosing this clinical position was to gain the perspective and experience in the leadership role. In the leadership role, I wanted to identify supervisory practices that promote good performance, workforce commitment, and professional satisfaction. A second learning goal and objective for this clinical was to identify key skills that nurses should develop to excel as leaders and managers. During my practicum, I have experienced different leadership styles, conflict resolution techniques, and the importance of effective communication across multidisciplinary teams. Some of the characteristics of a divisional charge nurse is having a strong foundation of clinical knowledge and skills on which to base judgment and make decisions, organize abilities to direct nursing tasks and operations, and interpersonal skills to facilitate communication and the work of others. Another learning goal and objective of this clinical site was to identify the educational needs of staff regarding spine mobility and precautions. My practicum site is the only level 1 trauma center within a 70-mile radius. The majority of trauma patients have some sort of spine injury. There are approximately 12,000 spinal cord injuries each year, which are associated with a significant mortality rate. There is an estimated 36,000 spine fractures each year. Most traumatic spine fractures are treated non-surgically with a 1 to 3 month period of immobilization and bracing, which can include, but is not limited to, the C-collar and the TLSO brace. Unstable fractures and those with neurologic impairment may require surgical treatment, extensive rehabilitative services, and often develop long-term disability. There's currently no formal education during orientation to this specific unit regarding spine mobility education or precautions. It is currently something that is just learned on the job. But for something that can have such catastrophic effects if performed inappropriately, there should be formal education and review to ensure competency. Spinal orthotic bracing is associated with risks such as pressure ulcers, dysphagia, and respiratory difficulties. These risks increase when nursing is not properly trained on the use, application, adjustments, and purpose of the spinal orthotic device. One study was conducted to assess the effect of an intervention on critical care nurses to improve their clinical knowledge and comfort level of managing spinal patients. A spinal course conducted by 2 orthotic residents was created for nurses with pre- and post-assessments. The results were concerning and suggested more education for trauma nursing staff regarding the proper use of orthotics. The study suggested that an in-service presentation should be performed annually regarding spinal orthotics. There is currently no formal annual education at my institute where I'm doing my practicum that regards spinal education. There are competencies that nursing is required to perform once a year that goes over skills such as the use of the code cart, how to properly tape an NG tube, the use of the striker beds, how to properly use the level 1, the CRT machine, but nothing regarding spinal braces or mobility. The American College of Surgeons requires that all trauma centers must engage in professional education and the hospital must provide documentation of current trauma education preparation of nurses. The American College of Surgeons requires education but does not specifically recommend a mechanism to evaluate competency or qualifications. Because there's no requirement for mechanism of evaluation of competency, there's a wide variance of education standards for nurses caring for trauma patients. One article discusses the process of identifying and establishing standardized trauma nursing objectives. 3 objectives able to directly impact nursing education and indirectly optimize patient outcomes were identified. First, the RN caring for the injured patient will be able to define predictable clinical manifestations relative to the mechanism of injury. Second, the RN caring for the injured patient will be able to describe a basic trauma nursing assessment and identify appropriate interventions based on pathophysiology, clinical manifestations, and medical nursing management principles. The third objective, the RN caring for the injured patient, will be able to identify the interventions needed before transferring the patient to the next step in definitive care. Based on these objectives, education regarding the mechanism, pathophysiology, assessment, interventions, and mobility restrictions of spinal injuries should be provided and assessed annually among trauma nursing. Nurses need to be able to identify the difference between an unstable versus stable spine fracture and the different types of fractures. For example, during my own personal assessment during my practicum, many of the nurses could not identify the difference between a burst fracture and a compression fracture. Nurses in trauma, I think it's easy to forget the pathophysiology of things because you are dealing with such acute injuries that can be so localized. But it's important to know the pathophysiology of these mechanisms. For example, a burst fracture is much more significant than a compression fracture because of the chance of long-term neurologic deficits you can have from it. So I think it's important to add in to the annual competencies not only the use of the orthotic devices as discussed on the previous slide, but also the mechanisms of injury and the different types of injury and the pathophysiology behind that. That way, if you have a patient with a burst fracture versus a compression fracture, you're aware of the significance of that. Lifelong learning and competency are mainstays of nursing practice. Patients expect professional nurses to be competent in their practice and in the care they provide. Individual nurses are accountable for their practice. However, lack of time, limited access to educational resources, or cost concerns are some individual barriers that nurses face when maintaining competency. Most nurses rely on some type of continuing education to help maintain and assure their competency. One study evaluated the barriers to nursing education and provided some suggested resources to help overcome these barriers and assure the education and competency of nurses. The study suggested role-based competency assessment and mandatory education, along with required contact hours specific to your area of practice. The site that I am doing my practicum at does currently require role-based competency and assessment each year, but caring for spine injuries and proper use of the orthotic equipment is currently not a part of the required competency. As explained on the previous slides, multiple research articles support yearly role-based competency assessment and mandatory education to maintain nursing responsibilities and competency caring for patients with spine injuries and proper use of orthotic devices. As previously stated, my institution does require annual competencies, which include the use of restraints, code cart, striker bed, NG tube, level 1, and CRT. However, there is no current competency or required education regarding the spine and orthotic devices such as the C-collar and the TLSO brace, which are the two most commonly used on the trauma floor. The changes that need to be made include the mandatory education of spine injuries in the form of web-based training with a post-assessment test for evaluation, in-person competency training and evaluation, including the use of and application of the C-collar, TLSO brace, as well as log rolling and holding C-spine should also be required annually to assure competency in using these devices and maneuvers when caring for a patient with a spine injury. Leadership is something I have always been interested in my practicum with the divisional charge nurse of the trauma surgical service line provided me with great insight and a new perspective. The DCN has many roles and responsibilities, including providing assistance with staff mentoring and educational support, which is why I chose the evidence-based practice topic of spine mobility and precautions education. Viewing the nursing staff from a supervisory perspective instead of a peer gave me the opportunity to evaluate the educational needs with the obligation to make changes that would better equip the trauma nurses to care for the specific patient population, which would indirectly optimize patient care and outcomes. The DCN must be armored with a multitude of communication and leadership skills, giving them the ability to adapt to different situations and provide the most effective response. The most valuable experience that I will take away from the practicum is the leadership and communication skills required and the transition between them to effectively lead staff.